I welcome all. Yes, all the PGs, all the judges. So let me introduce my coordinators. We are Dr. Preeti Kamdar madam here, Dr. Shirish Thorat sir, and myself, Dr. Siddharth Kamble, are coordinator here. And the judges, I would like to welcome Dr. Milind Killedar sir, renowned ophthalmologist from Sangli, Dr. Manoj Sasavade sir, renowned VR surgeon from Aurangabad, Chhatrapati Sambhajinagar, and Dr. Rajesh Joshi sir, associate professor at Government Medical College, Nagpur. So without wasting time, to start with, I will invite first speaker, Dr. Pratiksha Gaikwad. Dr. Pratiksha, share your slide.
Yes.
Over to you.
Thank you, sir.
All the best.
Thank you, sir. So, good afternoon, everyone. My topic is ocular viscosurgical devices. OVDs are the solutions having viscous, elastic, and pseudoplastic properties. All thanks to Dr. Enter, who has introduced us with the viscoelastic. Sodium hyaluronate was the first OVDs used in 1972. What is the need for the OVD? It is used for the protection of endothelia, maintenance of the anterior chamber depth. It is for the capsular axis. In IOL implantation, it helps in a correct position of the IOL. It improves the intravisibility. Ideal OVD should be inert, isoosmotic, non-toxic, non-inflammatory, cohesive enough to be removed easily, viscous enough to prevent the collapse of anterior chamber, elastic enough to enhance the coating and shock absorbing, and cost effective. There are some rheological and physical properties of the OVDs: viscosity, viscoelasticity, pseudoplasticity, surface tension and rigidity, cohesiveness and dispersiveness. Cohesiveness is a tendency to adhere to one another. It is important for the space maintaining. Dispersiveness is the tendency of a material to disperse when injected into the anterior chamber, and viscoadaptability. We have three products as a pharmacological agents. Sodium hyaluronate 1%. It is used for it is used as a main component for a dispersive OVDs. Chondroitin sulfate 4%. It is primarily used for the corneal endothelium protection. Then HPMC, hydroxypropyl methylcellulose 2%. It is a main component of dispersive OVDs. OVDs are broadly classified into three types: viscocohesive, which has a high viscosity. It tends to maintain the shape and enlarge and stabilize the size of the pupil. Viscodispersive, having the low viscosity, it provides the excellent coating over the corneal endothelium. Viscoadaptive is a cohesive at lower flow rate and dispersive at a higher flow rate. In this video, we can see there is a dispersive OVDs is instilled in a eye, and it provides the protection to the corneal endothelium. In second video, first we instill the dispersive OVD and then cohesive OVDs to maintain the anterior chamber depth, and then we do the capsular axis. Now, what are the uses of the OVDs? In cataract surgery, in the capsular axis, in cleavage of lens structure, nucleus emulsification, irrigation and aspiration, capsular bag filling, and IOL implantation. In soft shell technique, we use the both properties of the dispersive and cohesive OVDs together. Other ocular surgeries which used OVDs are glaucoma surgery, in viscocanalostomy, in keratoplasty, in posterior segment surgeries. In strabismus surgery, repeated probing and irrigation, in TCR surgeries, in cannular repair. The recent advances are OVDs are used as a viscose staining, in which dye mixed with the OVD stain then it stain the anterior lens capsule. It is used as a viscomydriasis also. In viscoanesthesia, mixture of OVDs with the lidocaine is used. In topical, 0.3% of hyaluronic acid with the 2% of lidocaine is used. In intracameral, 1.5% of hyaluronic acid with 1% of lidocaine is used. Choice of OVDs plays a crucial role in management of complicated cases, like in endothelial dystrophies, dispersive OVDs are used. In intraoperative floppy iris syndrome, we use the cohesive OVDs. In small pupil, we use the cohesive OVDs. In dense cataract, we use the dispersive OVDs. If we do not remove the OVDs properly from the anterior chamber, it leads to some complications. Most important one is the post-operative increase in the intraocular pressure, crystallization of the IOL surface, capsular block syndrome, corneal edema, calcific band keratopathy, iritis, hypersensitivity reaction, etc. Can you guess who is this gentleman? This is Dr. Steve Ashinow. He introduced us with the soft shell technique. Thank you so much and happy Independence Day to all.
Excellent. So now,
Very
judges, can you ask question?
Very nice. Suppose if you don't remove viscoelastic, what will happen?
Thank you for your question, sir. If we do not remove the OVDs from the anterior chamber, it leads to the increase in intraocular pressure. It is because the OVD material is accumulated in the trabecular meshwork and it leads to the stoppage of the oil flow and increase in intraocular pressure. It occurs within a 6 to 24 hours and it resolves within a 72 hours.
Okay. The most important complication which may occur.
Mainly the increase in intraocular pressure is the most important one.
Okay. Yes, I think
Given a
that
choice, Pratiksha, which OVD you would like to use in each and every case?
Sorry, sir, in?
Given a choice, which is the OVD of choice?
Now we use the soft shell technique mostly. So we use the dispersive OVDs to cover the endothelium, to protect the endothelium. And then we use the cohesive OVDs to maintain the anterior chamber depth. And we use the balanced salt solution to easily use easily the instrument. We can use easily the instrument in the intraocular.
Okay.
Thank you, sir.
Yes. We'll go for the next case.
Dr. Milind Killedar, sir.
Yeah, I'm okay with it. No
Yeah,
additional question. No additional question.
Okay, sir. Okay, sir. So we'll.
Thank you so much.
So we'll. Okay. Thank you, Pratiksha. So we'll go with our next speaker, Dr. Madhav Shah from Topiwala National Medical College. Dr. Madhav, share your screen.
Pratiksha was also
Yes,
from Topiwala, no?
Yeah,
Yes,
yeah.
yes.
Hmm.
Yes,
From
sir.
They
Yes.
have a team.
Yes.
hello. So now can you hear me?
Yes, we can hear you. But
Yeah, you can
try-
continue.
Okay.
Hmm?
Yeah. So,
Okay.
good morning, dear students. I am your teacher for today, Dr. Madhav, and I'll be explaining your congenital ptosis. So, what is ptosis? Ptosis literally means falling off in Greek. Blepharotosis is the state of drooping of one of the both of the upper eyelids with the eye in the primary case. What are the different types of congenital ptosis? So congenital ptosis can be simple congenital ptosis, or it may be associated with other anomalies such as superior rectus muscle weakness, Marcus Granjow winking ptosis, associated with blepharophimosis syndrome, and other less common causes. Now this is a collage showing different types of congenital ptosis. Simple congenital ptosis is idiopathic in origin, and it can be differentiated from acquired aponeurotic ptosis. In simple congenital ptosis, the upper eyelid crease is poorly formed, there is reduction in levator function, and on down gaze there is lid flap. In double elevator palsy, which is seen in 5% of the cases of congenital ptosis, it is due to the common origin of the superior rectus and the levator muscle. What is blepharophimosis? It presents as autosomal dominant inheritance, and type 1 is associated with premature ovarian failure. It consists of telecanthus, epicanthus inversus, and moderate to severe grade ptosis with poor elevator function. Marcus-Granjow-Winkling syndrome is seen in 5% cases of congenital syndrome, and it is due to a misdirection of a branch of mandibular division of fifth cranial nerve to the levator muscle. Now, a patient of congenital ptosis presents with drooping of one of both of the eyelids, cosmetic concerns, head posture anomalies, and movement of the eyelid with the movement of the mouth. History, we need to ask for the onset, duration, birth history, any history of trauma, surgery, any systemic illness. Examination would include head posture, visual acuity. We need to exclude pseudotosis. We need to see for eyelid crease, absence or presence, jaw winkling phenomenon, absence or presence, Bell's phenomenon. For the measurement, we need to measure the vertical palpable height. We need to then measure the MRD1, the marginal reflex distance, which is the distance between the eyelid crease and upper eyelid crease and the corneal reflex. The MRD2, which is the distance between the corneal reflex and the lower eyelid. For the levator function test, we need to block the frontalis muscle and then ask the patient to look down and then look up. And it can be divided into normal, good, fair, and poor. For the management, for non-surgical, we can give rehabilitative classes. The aims of the surgery should be correction of the correct positioning of the eyelid, symmetry of the both eyelids. There should be no lag of ophthalmos and no corneal exposure. The options for the surgery are conjunctival Muller resection, which is indicated in mild ptosis. It involves the excision of Muller muscles and the overlining conjunctiva. Levator resection is a second option which can be done through Everbush approach, which is the anterior skin approach, and the Blaskowitz approach, which is via the conjunctiva, where the levator muscle is resected. And last is the frontalis skin surgeries, which can be used in severe ptosis with poor levator function, severe Marcus or gun-jaw winkling syndrome, or associated with third nerve palsy. Material used as silicone or tensor fascia lata. Technique might be Crawford, a double triangle technique, or modified pentagon. This is the slide covering the total surgeries which can be used. Thank you and have a very happy Independence Day to everyone.
Yeah, that was
It was-
nice presentation.
Yes,
I just want to ask you, what are the causes of pseudotosis?
Pseudotosis can be due to when there is deficient support of the eyelid within microphthalmia, anophthalmia, or artificial eye, or there might be contralateral proptosis or ipsilateral hypertropia.
Suppose the patient has got mild ptosis with good levator. What is the surgical option which is the best suited for that patient?
So we can go for Farcinella servant or Muller's muscle resection because as it is a mild ptosis with a good levator function. So.
Good.
Hello. Can you show the first slide, please?
Yes, sir. Just a
In the meantime, I'll put a question.
yes, sir.
So is it by mistake that it is congenial ptosis or by
Sorry,
to
sir.
say-
By mistake. Sorry.
So my question is, what are the limitations or what are the precautions you will tell beforehand operating for fascia lata or resection, levator resection? What patient should expect post-operative?
So we can explain the patient that he or she will need a regular follow-up, and there might be complications like undercorrection and overcorrection, and we need to take care from where we have the wound area from where we have taken we have
Two things are important. One is that the eye will remain open during the sleep. And while looking down, there will be lid lag because the
Lid
lid is
lag.
being up.
Yes.
So these two things, if you do not tell before operating patient, he will not be happy post-operatively in spite of having lid at a proper level. So these
Okay.
two things are must to be told before surgery. Okay.
Yes, sir. Thank you, sir.
Okay, we'll go for the next.
Okay, sir. So next speaker is Dr. Sunetra Patil from DY Patil Medical College. Dr. Sunetra?
Yes, sir.
Share your screen.
Hello, sir. Good morning, sir. I'll share my screen.
Yeah.
Good morning, all. Good morning, sir. My topic today is contraindications of laser refractive surgery. Yeah, laser refractive surgery mainly involves excimer laser, femto laser, and holmium YAG laser. So in the entire laser spectrum, the excimer laser is in the ultraviolet spectrum, and the femto laser is in the infrared spectrum. So mechanism by which the lasers in the refractive laser refractive surgeries work. So one is by the photoablation, one is photodisruption, and photothermal. In photoablation, basically there's ablation of corneal tissue by breaking of the corneal by breaking of the carbon-carbon and carbon-nitrogen bonds with the excited dimer, that is the excimer laser. Uh, is the argon fluoride laser is the excimer laser, 193 nanometer wavelength. In the photo disruption, it is the femto laser. In the infrared, near infrared wavelength, the laser energy of a precise in the in photo disruption, laser energy is hit on the cornea in a precise location, and microplasma is created, and the plane of the tissue is separated. It is used to create incisions and flap formation. Photothermal, photohomium YAG laser is used in the uh, photothermal technique, and it is used in hypermetropia, causing collagen shrinkage from heat. So laser refractive surgeries today we have are the surface procedures and the lamellar procedures. Surface procedures is the PRK, LASIK, epiLASIK. In topography guided, we have contour vision surgery, and in lamellar, in which the flaps are involved, are of two types: mechanical LASIK, and laser assisted LASIK, and also small incision lenticle extraction, that is a SMILE. So, my main topic, my topic, contraindications. Now, the contraindications for the laser refractive surgery are first, unstable refractive error. We should have a stable refractive error. Age of the candidate less than 18 years. One-eyed individual. And now for PRK, myopia greater than -6 diopters, astigmatism up to 3 diopters, and higher hyperopia are the contraindications for PRK. LASIK, hypermetropia greater than +4 diopters, astigmatism greater than 5 diopters, myopia greater than -12 diopters. Depending now, this everything depends on corneal thickness. SMILE, in the small incision lenticle extraction, myopia greater contraindication for it are myopia greater than -10 diopters, and astigmatism is greater than -5 diopters. Right now, till now, SMILE is not being used in the correction of hyperopia. Now, corneal thickness is a very important uh, factor for the refractive surgery, for any refractive surgery. Now, contraindication of corneal thickness less than 470 microns is a contraindication. Cornea not too flat or steep, less than 36 diopters or greater than 49 diopters optics. Retinal diseases and degenerations. Before performing any laser refractive surgery or refractive surgery, retinal pathology should be evaluated. No, any retinal pathology like lattice degeneration, retinal breaks, myopic degeneration, history of RD or family history of RD, retinitis pigmentosa, or diabetic retinopathy are contraindications. Glaucoma is also the contraindication for laser refractive surgery, as after performing the refractive surgery, we reduce the corneal thickness, and corneal thickness uh, hence gives us false low IOP in a glaucoma patient. Then corneal ectasias like keratoglobus, keratoconus, Palisade marginal degeneration, Terence marginal degeneration, any
You need to
corneal
unmute.
dystrophies, recurrent corneal erosions, recurrent herpes, chronic uveitis, cataract, dry eye syndromes, any of the lid disorders, ectropion, entropion, mebomitis, chalazion, any exposure keratitis. So these are the ocular contraindications. Along with the ocular contraindication, there are also systemic contraindications like autoimmune diseases, connective tissue disorders, cancer, immunodeficiency states, pregnancy and lactation, as there are hormonal changes, corticosteroid, like patients on drug like corticosteroids, immunosuppressants, we delay the healing. In patients with cardiac pacemaker, implanted defibrillators, and also diabetes mellitus. Thank you.
It was excellent. Before going to judges' questions, I just want to remind all the participants, please stick with your 4 minutes time. Okay. Otherwise, you will be compromising your 1 mark of timing. And so please stick with your 4 minutes time.
Yes.
Sunetra, can you ask
Yes.
one question? What
Yes.
is there any absolute contraindications for refractive surgery?
Absolute contraindication is corneal thickness first, and like age of the patient and corneal thickness is
I think keratoconus should be the first absolute contraindication.
correct.
What are the options if suppose the
If the
patient
patient
is
is having collagen vascular disorders, autoimmune disorder, then will you do the LASIK procedure?
No, sir.
Ileta, sir, you can ask. No.
Yeah, I think there's a bit confusion from your side. Wrong selection of topic for a 4 minutes job. You should have selected either one of the lasers. You have included all the lasers and took about 2 minutes of time in explaining what are all the lasers. And the topic was complications. So you got less time for complications. So next
Yes.
time be a little choosy about your topic considering the timing. Okay.
Yes.
Good.
Thank you, sir.
Rajesh, sir.
Yeah, I
Right.
think we'll go for next presentation.
Yeah, well,
Okay,
Yeah.
sir.
yes,
So-
best tried. Well tried.
Dr. Sunetra, you stop sharing your screen.
Okay, sir.
And okay. Now next speaker is Dr. Sambhavi Sahai. He is also
Yes,
from
sir.
D.Y. Patel Medical College.
I'll share my screen.
Yes.
Good afternoon, everyone. My topic is optic disc examination in glaucoma. Glaucoma is characterized by progressive loss of retinal ganglion cells. It manifests as characteristic structural changes in optic nerve head, retinal nerve fiber layer, parapapillary area. Clinical methods of evaluation include direct ophthalmoscopy, slit-lamp biomicroscopy. It is the preferred mode since it provides good stereopsis and magnification. OCT RNFL, indirect ophthalmoscopy. OCT RNFL, it is an objective method of evaluation. It is good for documentation purpose and follow-up examination. There are normal variations in optics disc. The optic nerve head shape, it is normally slightly oval. Vertical diameter is more than the horizontal diameter. Variations include dotted optic disc, tilted optic disc. Neuroretinal rim, it is the tissue between the cup and the disc margin. Constituents include capillaries, glial cells, astrocytes. The axons at the superior and the inferior poles, they have less structural support and crowded, hence more prone for glaucomatous damage. Parapapillary area, it is the junctional zone between the optic nerve head with the underlying choroid and sclera. Two zones, alpha zone, beta zone. Alpha zone is away from the disc. Beta zone, it is adjacent to the disc. Beta zone is more important for glaucoma progression. There are various signs for glaucoma, mechanical signs as well as vascular signs. The assessment of optic disc, it comes under 5 R's. The first R is the scleral ring. First step includes the estimation of the optic nerve head size. Observe the scleral ring to identify the limits of optic disc and its size. Size determines the apparent estimation of neuroretinal rim and cup disc ratio. A large disc will have a large cup, an average disc will have an average size cup, and a small disc which might not even have a cup. Optic nerve head changes in small disc is often missed. Large disc with a large cup is often overdiagnosed as glaucoma. Second R is neuroretinal rim. It is the width between the outer edge of the disc and outer edge of the cup. It follows the ISNT rule, crucial in identifying localized rim loss. NRR thickness, pattern of NRR loss in glaucoma, it's the violation of ISNT rule, vertical or oblique cup enlargement, selective loss of NRR in inferior and superior sector. The NRR color, normal disc is pink, NRR with pale cup. If the rim pallor is more than the cup pallor, it points more towards non-glaucomatous neuropathy. And if the cup pallor is more than the rim pallor, it points more towards glaucomatous neuropathy. Cup disc ratio, a vertical cup disc ratio of more than 0.7 and a CDR asymmetry of more than 0.2 separates healthy from glaucomatous disc. Assessment of vertical CDR taking the optic disc size into account improves accuracy. Asymmetry of the cup, presence of an asymmetrical cupping of more than 0.2 in similar disc size disc is suggestive of glaucomatous damage. Retinal nerve fiber layer, there are mainly two types of losses, localized loss, diffuse loss. Localized loss, it consists of slit defects as well as wedge-shaped defects. Parapapillary region, normal ONH is surrounded by zones of varying width and circumference, alpha and beta zone. Beta zone is important in glaucoma. Its progression is associated with the progression of glaucoma. Fifth R is your retinal and disc hemorrhages. Drans hemorrhage, it is more common in normal tension glaucoma. Hemorrhage is present in the nerve fiber layer. They are feathery or flame shaped. There are various vascular changes in optic disc, which include nasalization of vessels, barring of the circumlinear vessels, bayoneting of vessels. To summarize, documentation of findings. First, observe the scleral ring to identify the limits of optic disc and its size. Size, measure the vertical diameter. Describe whether it's small, medium, or large. Then identify the size of the rim. Rim, is the ISNT pattern followed? Is there any localized thinning? Is there any pallor? Examine the nerve fiber layer for any defect. Examine the parapapillary area. Look for retinal and optic disc hemorrhages.
It was good.
Thank you.
So judges,
Yeah, nice presentation.
Thank you, sir.
Out of the modalities you have mentioned, which one you will prefer?
So most preferred one is slit lamp biomicroscopy. With the help of 78D and 90D lens. After that, we'll use the OCT RNFL.
Fine, I just put one modality only.
Hello.
Shirish sir mute kara.
What is the earliest sign of glaucoma in nerve fiber layer?
So it's nasalization of vessels. They take place.
No.
Cup distillation.
Mhm. You know wedge-shaped defect?
Yes.
Which is seen through red-free filter.
Yes, sir.
If the pressure is normal,
Yes, sir.
fields are normal,
Yes, sir.
and you are suspecting glaucoma, how will you proceed?
So that can be a case of normal tension glaucoma. We'll make sure that the IOP is it's maintained in a range in the normal range, and so we won't first start with the drops. We'll do all the baseline testing and then follow up the patient, and if we find any changes, then we'll start with the drops.
Okay, okay. Go for the
In fact, you
next.
have to look for progression. Okay.
Yes.
In normal tension glaucoma, whether progression is there or not, you have to
Yes.
look for that.
Yes.
Okay. Before proceeding, students, when you are answering the questions of judges, you have to keep your video on. Okay. So next speaker is Dr. Shamli Raut from JJ Hospital and Grand Medical College. Shamli.
Yes, sir. Good afternoon.
Share your.
So before I start, I would really like to thank all for this great opportunity. Thank you. So I would like to, I'll start sharing. Good afternoon, everyone. I would be talking about the only natural tempered glass of the eye, cornea. I'm Shamli Raut, and I am a resident from Grand Government Medical College and Sir JJ Group of Hospitals. So to start with the start of all this, that is the embryology. Cornea generally develops from two things. The epithelium develops from the surface epithelium, and the other layers develop from neural crest cells. The first layer, corneal endothelium, the last layer generally develops in the first wave, and to the contrary, the stroma develops from the third wave. Now, quickly brushing through the anatomy, as we all know that cornea is not spherical, though it looks like. It is prolate in shape with vertical diameter more steeper than the horizontal one. And it contributes maximum power of the eye, that is 40 to 44 diopters, as compared to the total 60 diopters of the eye. The central 5 mm being more spherical is the most powerful refractive surface. Now, all these anatomical dimensions, why are they so important? So, these are important to rule out microcornea and megalocornea. Microcornea is generally associated with micro and nanophthalmos and iris coloboma, and while megalocornea is generally related to buphthalmos or congenital glaucoma. Quickly moving on to the microscopic anatomy. As we all know, the ABCD of ophthalmology, the anterior epithelium, the Bowman's membrane, the collagenous stroma, the Descemet's membrane, and the endothelium. And a very proud and novel addition to this is the pre-Descemet's membrane or the Dua's layer. So to talk about each layer, emphasizing on each layer and its clinical significance, epithelium is generally the stratified non-keratinized squamous epithelium. As we can all see in the picture, the lower layer is the columnar cells are generally stuck to the basal lamina by hemidesmosomes. Any defect in these hemidesmosomes would lead to recurrent corneal erosions, which are atraumatic in type. And any trauma to this layer generally leads to epidefect. Now moving on to the Bowman's layer. Bowman's layer, being a very thin layer is acellular, is considered to be a basement membrane, but it is not a true basement membrane as it does not regenerate when damaged. Generally, any damage to this layer would lead to corneal scarring or corneal opacity. So now talking about the stroma, the thickest layer of the cornea and the maximum part of it. Generally, any stroma should consider of a ground substance. So the ground substance here is the proteoglycan and with interspersed keratocytes in it and collagen lamellae. The keratocytes generally secrete both the ground substance and the collagen also. So now, what is the clinical importance is that you see the cornea and the sclera both have these collagen lamellae. But as you can see in the picture, the collagen lamellae are more uniformly spaced and uniform in diameter in cornea, while more interwoven, irregular, and ununiformly placed in sclera, which leads to the transparency in cornea as against the sclera. As I said, stroma is the thickest layer. Its thickness is generally reduced in keratoconus and corneal thinning. Now talking about the most proud layer, the Dua's layer, as it is discovered by an Indian doctor, Harminder Singh Dua. It is acellular and a very thin layer, but the most toughest layer. That's why in deep anterior lamellar keratoplasty, we inject the bubble below the Dua's layer, between the Dua's and the Descemet's membrane, to reduce the complications which were earlier there. Also, corneal height drops is generally due to any tear in this Dua's layer. Now moving on to the Descemet's layer. As you can see, Descemet's is the basal lamella of the endothelium and its peripheral termination is known as shawl base line. And in cases of ulcer, there is generally an complication seen known as descemetocele, which is nothing but the protrusion of this layer due to trauma to all the other layers above. Endothelium is the thinnest layer and generally it does not proliferate. It generally secretes the Bowman's layer continuously throughout life, but it itself does not regenerate, but it always but the defect is generally covered by enlargement of the cells present known as polymegathism, and this leads to the irregularity in their shape known as pleomorphism. Generally, the endothelium cells count decreases throughout life, thus leading to any trauma during cataract surgery, which generally occurs in old patients, can lead to corneal edema. Also, Fuchs endothelial corneal dystrophy, Fuchs endothelial corneal dystrophy is a genetic disorder due to a dystrophy. It is a dystrophy due to genetic dystrophy due to the damage to the endothelium. Corneal transparency. Corneal transparency is generally because of three things: the avascularity of the cornea, the lamellar arrangement of the collagen fibers, and its failure might lead to sclerocornea, and the state of relative dehydration caused due to the hypertonic tear film, the tight junctions of the endothelium and the epithelium, and the intraocular pressure being more than the stromal pressure, and the tight pump mechanism, endothelium pump mechanism, that is the sodium and sodium pump present in the endothelium. Quickly talking about the nerve supply, though it is the most avascular layer, it is richly innervated by the nerves, and that's why any trauma to the cornea is very painful. It can be easily remembered by the mnemonic TON, that is trigeminal layer, trigeminal nerve giving ophthalmic division and then to nasociliary division, leading to a long ciliary nerve. This long ciliary nerve will form a pericorneal limbal plexus, and these pericorneal limbal plexus will form stromal plexus, and these will form subepithelial and intraepithelial plexus. While these nerves
You
run
have
into the
taken
stroma.
6 minutes.
Okay. So now
Six.
I would like to thank you all. I would quickly talk about the classification of the limbus. Limbus can be classified into anatomical and surgical. The anatomical one is clearly the conjunctivo-corneal junction, and the surgical one is the landmark for all the incisions. So thank you so much for all the time. Thank you.
What is the volume of keratocytes in normal cornea, and in
Sorry?
which condition it depletes? What is the volume of keratocytes in normal cornea, and in which conditions it depletes?
So volume, I am not sure about, but sir, I don't know.
It was a good presentation, never mind.
Thank you, sir.
Next presentation, except for the time, I think you covered each and everything, but you should have looked at the topic which is being given to you, corneal anatomy only. You should not have covered limbus and all. Anyway.
Okay. Yes, sir. Thank you.
Okay, Dr. Sasade, sir.
Next candidate.
Next, okay, sir. So next speaker is Dr. Shalu Baidwal. He is also from JJ Hospital and Grand Medical College. Dr. Shalu.
Yes, sir.
Okay, you are sharing from the same instrument, na?
Yes, sir.
Okay.
Yes, sir. Good afternoon, everyone. I'm Dr. Shalu Biadwal, first year resident of ophthalmology from Grand Medical Grand Government Medical College and Sir J.J. Group of Hospital, presenting a brief session of vitreous substitute in front of you. Why do we need vitreous substitute? In retinal diseases such as retinal detachment with proliferative vitreoretinopathy, traumatic retinal detachment, proliferative diabetic retinopathy with tractional RD, and in pediatric population, RD associated with retinopathy of prematurity, we have to substitute vitreous. An ideal vitreous substitute must be clear and transparent and insoluble in water, easy to manipulate during surgery, and have similar reflective index to human vitreous. It must be biodegradable, biocompatible, and does not block aqueous drainage and non-toxic to retinal tissue. And till now, an ideal vitreous substitute does not yet exist. We have two types of vitreous substitute. One is gases and liquid. In gases, we have air, we have sulfur hexafluoride, perfluoropropane, and in liquids, we have saline, silicon oil, perfluorocarbon liquid, which we also say as PFCl, and we have semi-fluorinated alkenes. In gases, first to use our gases, they act used as internal tamponade due to high surface tension and specific gravity lower than water. Patient must be advised to sleep in prone position and face down position, opposite side of the brain, to provide that tamponade effect to the eye or tear. One of the advantage of air is that we don't have to remove it. Room air begins to shrink immediately after injection. It requires short prone position and allowing a faster recovery. Other gases we have sulfur hexafluoride and perfluoropropane, which is C3F8. These gases are lower water solubility than nitrogen. That's why in patients with these gases, we advise to avoid air and high altitude travel, scuba diving, and general anesthesia, as these gases in low atmospheric pressure expands and lead to increase in intraocular pressure. Complications with gases are they can lead to formation of cataract if they come in contact with lens. If they came in contact with cornea, it can lead to secondary corneal decompensation. It can lead to hypotony if there is any leakage. In liquids, we have saline solution, balanced salt solution, which is similar to aqueous humor, and it does not provide any tamponade effect. So we used them temporary basis during exchange. Second way, most commonly we use silicon oil. Most commonly used silicon oil is polydimethylsiloxane, PDMS, which is transparent and hydrophobic substance and has specific gravity slightly lower than water and has higher surface tension and reflective index than normal vitreous. It is available in different viscosities, ranges from 1000 to 5000, and it is measured in centistokes. We have one silicon study in which we compare between the silicon oil, SF6 and C38. Disadvantages of silicon oil are it changes in optics and refractive indexes, like in phakic and pseudophakic. There is hyperopic shift. In phakic, there is myopic shift. It is less effective in inferior break, and we have to remove silicon oil after some period of time. PFCl, they have high specific gravity. Most commonly used is C3F8. It allows repositioning during surgery. It provides best currently available internal tamponade during membrane dissection. Then we have heavy silicone oils, heavier than water. We have three types of in market: Densiron 68, Oxen HD, and HW at 46-3000. Then we have double fillings in which semi-fluorinated alkaline sinks and silicone oil floats. It provides superior and inferior tamponade simultaneously. It commonly used in complicated RD. Like in picture, there is sandwich technique we used in surgeries. This is the brief of advantages we already discussed. Now in a newer thing, we have vitreous regeneration, which is in experimental till now. And we have vitreous implants, foldable capsular vitreous bodies. That's it. Thank you so much.
It was good.
Thanks.
I think Dr. Manoj Sasode sir must be ready with bunch of questions.
No, not in this. How many days the SF6 gas tamponade effect lasts?
The FS6 40 days, months. roughly a month, 2 months.
SF6 2 months. Okay. And what about C3 effect? You tell me about the silicon oil tamponade effect. How many days it lasts? Okay.
Sorry,
It
sir?
lasts SF6, you just last for 12 days, 12 to 15 days. C3 effect 6 weeks. And silicon oil as long as you are keeping inside. Okay. You don't have to remove the silicon oil.
Yes.
Where will you use PFCL or heavy liquid perfluorocarbon?
So PFCL we use in membrane dissection when there is fluid. We have we have to remove subretinal fluids, we use PFCL. Then there is I just an image in my presentation, sandwich technique, in which we use PFCL to compress the tear. Fluids floats over the PFCL, and then we put silicone oil. It gets removed. To remove fluids, basically.
How long you can keep PFCL?
Don't know why.
Okay, good. Rajesh, you can ask.
Yeah, I think that was a nice presentation. I will just
Thanks.
ask a basic question like, what is the volume of vitreous?
So 4 ml.
Yeah, nice. And the corneal complications of silicone oil?
So corneal complication silicone oil. So if it's come in contact, first of all is when the oil emulsified, it deposits in the anterior chamber. It can lead to hyperleon, and if it come in contact, it can lead to secondary decompensation of cornea.
Good.
Thank you, sir.
Killedar, sir.
Good enough. No questions.
Okay, sir. So next speaker is Dr. Arushi Vaishnavi. Dr. Arushi Vaishnavi. She's from Terana Medical College, Navi Mumbai.
Yes, sir.
Okay. Arushi, share your slide.
Good morning, everyone. I'm Dr. Arushi Vaishnavi from Terna Medical College and Hospital, shining light on dyes in ophthalmology used for diagnostic and therapeutic tools. The first dye is fluorescein, which is an orange-white water-soluble dye that highlights areas of epithelial breakdown. The molecules absorb light of lower wavelength in blue spectrum and emits higher wavelength green light. As 70% plasma protein bound, it is used intravenously for fundus fluorescein angiography. It is used for diagnosis of dry eye, for tear film breakup time measurement, and tear meniscus height. It is also used for corneal epithelial defects, corneal ulcers, and corneal abrasions. In perforating injuries, it is done to perform Siedel's test, and for testing NLD patency, for example, in Jones disappearance test. It is also used in applanation tonometry, fundus fluorescein angiography, and contact lens fitting. It is readily available as strips. It causes no ocular toxicity, but it is not effective in delineating choroidal vasculature. The next dye is Lissamine green. It is an acidic dye used for staining dead cells, preferred for staining bulboconjunctiva. It is used for diagnosing dry eye disease, to rule out keratoconjunctivitis sicca and lid viper epitheliopathy. It is also used in fitting of contact lens and to look for any contact lens induced conjunctival staining. It causes no ocular discomfort and produces less ocular toxicity, and hence is preferred over rose Bengal stain. But it needs to be used in a larger quantity, and it is not contact lens compatible. Moving towards rose Bengal, it is another halide derivative of fluorescein used to stain dead cells in ocular surface disorders. It is used in conjunctival staining for diagnosing dry eye disease and dysplastic or squamous cells, metaplastic cells of conjunctival squamous cell neoplasms. It is used in corneal staining for herpetic corneal epithelial dendrites and superficial punctate keratitis. Also used in meibomian gland dysfunction. It can early detect ocular surface disorders, but produces high degrees of ocular toxicity than other dyes. And even the presence of lubricating eye drops interferes with uptake of the stain. Trypan blue helps in visualizing anterior capsule by selectively staining Tenon's capsule and epiretinal membrane. It is used in staining the anterior capsular lens during cataract surgeries and to stain and strip the Descemet's membrane in DSEK and to strip the corneal endothelium in DALK. It is also used for posterior segment surgeries to stain the ERM. It is FDA approved, ready to use solution is available for this dye and it stains immediately. But it has to also be washed quickly to prevent staining the other ocular tissues. And it is not easily available to be used with acrylic IOL as it causes permanent staining of IOL. Indocyanine green stains type 4 collagen and laminin found in ILM. It is used in chromovitrectomy to visualize the ILM, in indocyanine green angiography to visualize choroidal circulation for polypoidal choroidal vasculopathy, choroidal neovasculature membrane, and age-related macular degeneration. It gets washed out very quickly and is better tolerated than in FFA, especially with eyes containing media opacities, and gives clearer fundus picture compared to FFA. But the property of decomposition can cause retinal toxicity, and the dye can remain in the vitreous even after surgery. It is also not FDA approved for intraocular surgery. Triamcinolone acetonide is a non-soluble corticosteroid that binds to vitreous and ILM. It is used during vitrectomy. The dye binds as crystals on the vitreous and facilitates complete detachment and removal of the posterior hyaloid. And it is also used to check vitreous strands that are left in AC after anterior vitrectomy in posterior capsular rents. There's no reported retinal toxicity, and the vitreous is easily visualized in posterior segment surgeries, but it is found in the vitreous up to 40 days after injection, and it accelerates cataract and increase in IOP. Brilliant blue has a strong affinity for internal limiting membrane without staining ERM, and has the property of double staining, where ERM is peeled against blue ILM followed by staining and peeling of ILM after instilling dye again. It is used in staining the ILM in posterior segment surgeries. It is FDA approved and safer than indocyanine green, but atrophic changes have been reported in fewer cases. Other dyes like bromophenol blue and patent blue are also used for ILM staining and are less toxic than indocyanine green, but they are not FDA approved and hence not used frequently. Thank you.
Good.
Yeah, nice presentation, Vaishnavi.
Thank you, sir.
One question, what is the concentration of Trifamli which is used for cataract surgery?
Trifan blue, sir, it is used. Sir, I don't.
Okay, fine. Concentration of fluorescent strips, fluorescent dye.
The fluorescent strips are used as 1 to 2% solution in bottle form, and the strips contain 1 microgram of the dye.
And for injection?
Sir, for
Like
injection,
fluorescent-
10% and 20% concentrations are available.
And amount of dye in 10% and 20%?
So there are vials. 5 ml vial has 10% dye, and the lesser quantity 1 to 2 ml vial has 20% dye.
Yeah, I think that was nice presentation.
Thank you, sir.
Except that this slide was too much of matter.
Can any dye induce stars?
So can any dye use?
Stars, TASS.
Arushi, keep your video on.
Sir, it's on.
Toxic anterior
Camera
segment.
is not on.
Sir,
Okay.
I don't know.
You know the answer? No.
No, sir.
Okay, fine.
Okay. Shall we proceed further?
Yes. Next.
Yes, sir. Okay. Next speaker is Dr. Anshika Dubey
Yes, sir.
from Terna Medical College only. Okay. Anshika, screen your share.
I think
Share your screen. And
we
again, I
just-
will remind all the students while answering the questions of judges, you have to keep your video camera on.
Good afternoon. Good afternoon and happy Independence Day to the esteemed panel and fellow ophthalmologists. Myself, Dr. Anshika Dubey, presenting the
Anshika,
topic.
you make a slide show.
Yes, sir.
Only slides should be visible.
Okay, sir. So is this okay?
No.
we can't see your slides. You can reshare, I suppose. Yeah, we
Sure.
can the classification.
But what is there written below? Just half slide is there. But
So with
maybe
this,
more.
so when I'm doing, it's coming like this. Can you see now, sir?
No, nothing.
No.
So is it visible?
No. I think
Go
you
with
reshare, I
more.
suppose.
Okay,
You
Okay,
sir.
go with.
and again reshare. So you can see your first slide.
Sir. And then, so this, is this okay?
But
Yeah,
what
we
is
can
there
see
below? That
it is not
half
full screen.
screen is there is some unwanted things are there. No comments on the slide or not.
So
Notes
that's
and comments
I'm
about
able to
presentation.
read that, sir.
Yeah, I think you present whatever.
Okay, go
Yeah.
ahead.
Go
Okay.
ahead. Your time starts, restart the time.
Yeah.
Okay. Go ahead.
Good afternoon. Myself, Dr. Anshika Dubey, presenting the topic differential diagnosis of MOS at limbus. The various conditions can be classified into one, congenital, example dermoids nevus; second, inflammatory, example episcleritis or scleritis; third, allergic nodules, example phyllectinicular vernal; fourth, vascular hemangioma; fifth, traumatic cyst granuloma or foreign body; sixth, degenerative pterygium penangula; seventh, nutritional, example Bitot spots; eighth, neoplastic, example malignant melanoma, lymphomas; ninth, miscellaneous, like amyloidosis. Common conditions are pterygium, which is a wing-shaped fold of conjunctiva consisting of head, neck, and body. Penangula is a yellowish, fleshy elevation. Both conditions are associated with risk factors of sunlight and dry eyes. Vernal is also known as endemic limboconjunctivitis and appear as Horner-Tranta dots at limbus and limbal hypertrophy. It's an IgE-mediated hypersensitivity response. Phyllectinicular is a localized allergic response to endogenous allergens, example tuberculosis and staphylococci. It's a type 4 hypersensitivity-mediated response. It's seen in malnourished and poverty-stricken areas. Cysts such as aqueous cyst, filtering bleb due to cystoid cicatrix healing, retention cyst due to blockage of lacrimal gland, epithelial implantation or traumatic cyst, parasitic cysts are also appear at limbus. Granuloma is a benign polypoidal growth of granulation tissue seen after squint surgery or foreign body. Dermoids are choriostomas present congenitally, removed only for cosmetic reasons as they do not grow in size. Nevi or congenital moles are common pigmental lesions present since childhood. Any change is suggestive of inflammation. Precancerous lesions also appear at the limbus, that is carcinoma in situ, Bowen's intraepithelial epithelioma, Bowman's disease. It's characterized by severe anaplasia. Dysplasia does not extend beyond the epithelium. Papilloma are epithelial tumors when neoplastic are sessile in nature. Malignant melanoma appear in elderly individuals, which may be pigmented or non-pigmented lesions. Squamous cell carcinoma is characterized by malignant cells invading the basement membrane. Lymphomas are painless, slow-growing tumors. They're characterized by salmon-colored, pinkish lesions at the limbus. Kaposi sarcoma is a vasculoformative mesenchymal tissue tumor with parasites and endothelial cells, seen in AIDS patient, that is seropositive patients and elderly, histologically classified into 3 types. First type without mitotic cells, second type without mitotic figures with hyperchromatic nuclei, third type with hyperchromatic nuclei and mitotic figures. Episcleritis and scleritis are conditions which may also present at limbus or few millimeters from limbus. They may present as nodules. When the nodules are multiple, they may be associated with sharp rise in intraocular pressure. They're associated with systemic diseases like Crohn's disease, rheumatoid arthritis, and ankylosing spondylitis. Other conditions such as amyloidosis, melanocytoma, angioma also appear as mass at limbus. Thank you for the time. Hello.
Yes, it was nice. Yeah.
That was wonderful presentation and followed time also. Just one question on gross examination. What are the signs of cancerous lesions?
So there'll be, so not sure, but it depends on the type of cancer also. So if, 1 second, so can you see me?
Yeah.
So it depends on the type of cancer also. So if it's lymphoma, it'll be slow growing and there'll be a characteristic pinkish lesion. But if it's a melanoma, then there'll be change in the color, there'll be hyperpigmentation. So it depends on the type of lesion, and diagnosis is based on histology only, since dysplasia has to cross the basement membrane to be called carcinoma and not a precancerous lesion.
Okay, that is fine, but I was expecting like ulcerations in the area, increased vascularity.
So yes, sir. Okay, sir.
What is the most common lesion at limbus you see?
So degenerative
degenerative.
conditions are most common.
Degenerative.
Yes, sir.
Okay.
Why is it common in the palpable aperture area? Pterygium you see mostly nasal or temporal, no? Why
Yes,
not
sir.
superior?
So no, not sure.
Read
But
about
yes, sir.
Coronius effect. Okay.
Yes, sir.
Good presentation. We'll go for the next.
Thank you, sir. Thank you for the time.
Okay. So next presenter is Dr. Diksha Kumare from Grant Government Medical College. Dr. Diksha?
Yes, sir.
Yes. Please share your screen.
Sir, is it visible?
Yes. Good. Excellent. Go ahead.
Good afternoon, all the judges, teachers, and my fellow colleagues. I am Dr. Diksha Kumre from Grant Government Medical College and Sir JJ Group of Hospitals. And my mentor is Dr. Shrutika Paul. And the topic of my presentation is refraction in children. So, refraction in children is a challenging process. So, what are the goals of pediatric eye and vision examination? It is for the evaluation of refractive, binocular, accommodative status of the eye and visual system, for the assessment of ocular health and related systemic health conditions, for the establishment of diagnosis, to formulate treatment and management plan accordingly, counsel and educate the patient, parent, caregiver regarding visual system and healthcare. So, pediatric eye examination, it should include the following: history related to antenatal history to rule out the torch infection, perinatal history, details of delivery, systemic and ocular history. Ocular history will contain misalignment of eye, rubbing of eye, watering, photophobia, etc. Ocular examination, it consists of vision assessment, external examination, ocular motility, pupillary examination, slit lamp examination, dilated examination, age appropriate cycloplegic refraction, and intraocular pressure examination if we suspect for glaucoma. So pediatric visual acuity charts are there. It framed according to age, 0 to 6 months and 6 to 12 month age, test should be done. Observation. Observe the child if there is head tilt or face turn or squinting. Corneal reflex by using torchlight. Fixation and following. Forced choice preferential looking test. Optokinetic test. Taylor acuity and Keller acuity test. For the age of 1 to 3 years, cardiac acuity test, preferential looking test, K-picture test, Sheridan-Gardiner test, Lee-Pedal test. For the age more than 3 years, same Sheridan and Gardiner test, HOTV test, Landau C-type test, Snellen-Logmar chart test. Here are some pictures of this chart. First is optokinetic nystagmus test. Showing strips of drums. We use it by alternate rotating clockwise and anti-clockwise direction. Second picture showing Teller and Keller acuity card test. It consists of 8 cards with the brightest and biggest card, and slowly reducing the contrast. We ask the child to look at these cards. Cardiff test, it is based on vanished optokinetic test, Lee-Pedal test. And similarly, K-picture test, it consists of series of cards. Sheridan-Gardiner test, similar. Now coming to retinoscopy. It is an objective method finding out the errors in refraction by utilizing the technique of neutralization. It is a gold standard method and we do it by cycloplegic drug method. Make the patient sit comfortable at a distance of 66 centimeters from the examiner. We can use it at working distance of 1 meter and 50 centimeter. Room should be semi-dark and the level of examiner and patient should be at the same height. As the patient to look at this distance vision chart with the help of retinoscope, we observe the red reflex of pupillary area. An interpretation, the reflex is with the movement, then neutralize the with the plus lenses. If it is against the movement, neutralize with minus lenses. And no movement, that is the neutralization point. We use some drug for cycloplegia like atropine, homatropine, cyclopentolate, tropicamide. And we call the patient for post-mediatic test. Post-mediatic test is a subjective test. It is the assessment of finding cyclorefraction after the test of cycloplegia. If atropine is used, the ciliary tonus should be subtracted. Not necessary in case of cyclopentolate. For special conditions, we prescribe the glasses like pseudofix and affix. We immediately prescribe the glasses. And for gross developmental delay, Down syndrome, and mental retardation, we give as early as possible. Myopic children should be advised to reduce screen time and spend more time for near activity like reading. Spectacles should be of lightweight and plastic frames. And we call the patient for follow-up. If the child is less than 3 years, we call the patient in every 6 monthly, and if more than 3 years, we call the patient yearly. Thank you.
It was good. Thank you, Diksha, for finishing it in time.
Hello,
Yes, sir.
Diksha.
Thank you, sir. Yes, sir.
What is preferred practice pattern, and age-wise, how minimum refractive error should be prescribed? That slide should have been there. It has been developed by even American Pediatric Ophthalmic Association and taken up by Orbis also. So it is a standard practice. What is the preferred practice pattern? At which age, what refractive error should be prescribed?
Okay, sir.
And a bit of mention about how to examine uncooperative children, like use of sedatives or chloral hydrate or taking help of natural sleep.
Yes, sir. Before doing refraction, baby should be fed up, full fed up.
Yes.
Or having good nap, then patient may cooperate with us for refraction. If it is a small kid.
Ask them to bring the child 3.5 hours NBM, and then after coming, you dilate, and after about half an hour or so, you give sedation on empty stomach, which is absorbed very well, and then give the feed. The child sleeps so well that you can even see tension. The refraction can be easily done. Okay.
Patient may be cooperative. Okay, sir.
Post-pediatric or post-cycloplegic test is done beyond which age?
So we can do it at all the ages. For adult
do it
also.
for 1 year. How can you do it for a 1-year child?
No. From school-going children to adult, we can do this test.
You cannot do it under 5 years. So post-pediatric is must beyond 6
yes,
years. Something. Okay.
Yes, sir.
Yes. Okay. Thank you.
Thank you, sir.
Shall we proceed?
Yeah, I think we will for next presentation.
Okay. Next speaker is Dr. Suniti Raut from
Yes,
Grand
sir.
Medical College.
Yes, sir.
Dr.
Can you hear me?
Yes, we can hear you. Share your screen.
Yes, sir. Is it visible, sir?
Yes.
Yes, please go ahead.
Okay, sir. Good afternoon, everyone. Happy Independence Day to all. And my topic is near intraocular lenses. I'm from Grand Government Medical College and Sir JJ Group of Hospitals. My mentor is Dr. Shrutika. And till now, we are using generation 1 to generation 6 intraocular lenses. And the newer IOLs we are currently using are mostly of generation 6 lenses. And after that, there are many more IOLs which are coming, like adjustable, telescopic, and electronic and smarter lenses. And the need for newer intraocular lenses is always been there because everything has it comes with its own perks, like dysphotopsia or need for spectacles, astigmatism, and loss of accommodation, and some any other things. So we need newer intraocular lenses, which is in progress. And the materials used are polymer, hydrophobic acrylic, hydrophilic acrylic, then PMMA, then silicon, and DHEMA copolymer. The newer designs currently, which are in a hot topic, are EDOF lenses, extended depth of focus, which augments intermediate vision and is more forgiving in ERM and post-LASIK surgery patients. And another is like extended range of vision lenses. Example like Panoptics and Technic Synergy lenses, which is partly trifocal and partly EDOF with good near vision. Then other ones are light adjustable lenses. Its main mechanism is macromer, which is a photosensitive material which changes its shape in response to UV light. And it allows post-operative titration of IL power and facilitates customization, and 3 sittings are needed usually to achieve this. Example like Technis iHands by Johnson and Johnson's company are being used, and Vista and Technis Symphony. These are lenses which are currently used in abroad. Mixing and matching type we can use like with EDOF in dominant eye and multifocal in the other eye. And monovision is better to achieve by keeping one eye emmetropic and one eye myopic, a little myopic. And VVT is another lens which is in very commonly used, and it's by Alcon only, which has a central bump, and it condenses light for near vision. And the main one good thing is patients can check their compatibility before opting for such kind of lenses. And there are drug-eluting IOLs which can be used as drug depots. We can use drugs like local anesthetics, esters, amides, anti-inflammatory drugs, antibiotics, benzodiazepines, anxiolytics, and other lenses like hydrogel, which are square-edged multifocal intraocular lenses. These are very good because these are biocompatible, and accurate refraction with clear vision are achieved by this, and less glare. And there's still a debate between hydrophobic and hydrophilic lenses for diabetic patients, because biocompatible lenses are good as it is more compatible with our body, but hydrophobic lenses are being used to avoid reactions and inflammatory conditions. Panoptics lenses and can be used as a near IOL, which improve astigmatism. Toric lenses, which have less astigmatism or negligible astigmatism, so which can be put in both the eyes, we use. An accommodative intraocular lens, which works on a principle of movement of pseudofix in the eye under the influence of vitreous pressure, changing with the accommodative effort. 1 mm equals to 1.8 diopters. My mistake, sir. And these are newer IOLs. And there are electronic and telescopic IOLs also, which are being used. There are many like roller or aniridia IOLs or piggy bank IOLs. So these are under debate only ki, whether should be, we are in a process only ki, whether this should be used or not. So there is a long growing curve ahead in future regarding intraocular lenses. So thank you so much.
Wonderful. Good.
Which is the most inert material, intraocular lens material?
Sir, silicon. Sir.
Silicon. Or is it a PMMA?
Yes, sir.
Is it a PMMA?
Yes, sir. PMMA also, sir.
Which you will prefer for an medico or ophthalmologist?
Sir, usually doctors are have to study a lot, so I'll use multifocal. Good.
Okay.
There must be a good near vision. All three visions would be. So I'll use multifocal, sir.
You can ask Raj.
Contraindication for putting in multifocal. Absolute
Is
contrast.
there a loss of contrast sensitivity in multifocal IOLs? Is there a loss of contrast sensitivity in multifocal IOLs?
Diksha,
I think she has lost connection.
are you there?
It is a Suniti.
Yes, sir. Yes,
No,
sir.
Diksha. Oh, Suniti, no?
No,
Suniti.
sir. We are sharing a same screen. That's why the name came in Diksha only.
Okay, okay. So, I will listen the question of Killedar, sir.
Is there a loss of contrast sensitivity in multifocal IOLs?
Yes, sir. There is a loss of contrast sensitivity.
That's the reason ophthalmologists are avoiding it for themselves. We need the best contrast, okay?
Yes, sir. Sorry, sir.
Okay. We'll
from
proceed for the next one. Thank you, ma'am. Good done.
Okay.
Thank you, sir. Thank you all.
Okay. So next speaker is Dr. Shubham Saurabh from Grand Medical College and Sir JJ Group of Hospital.
Hello. So can you hear me?
Yes, Shubham.
Okay. Good afternoon, respected teachers, and happy Independence Day to all respected teachers, honorable judges, and my dear colleagues. Myself, Dr. Shubham. I am first resident in Grand Medical College and Sir JJ Group of Hospitals from Mumbai. I'll be presenting my topic on biometry. So under the mentorship of Dr. Rushabh Sasar. So as the name suggests, biometry is the practice of applying mathematics to biology. And when it comes to ophthalmology, we really need to know several dimensions, and we need to have accurate measurement of an eye so that we can place, after the cataract surgery, when we place the intraocular lens, we give accurate vision to the patients. So as we all know, the refractive power of the eye is determined by various parameters like axial length, corneal curvature, lens, ocular media. So we need to take into account all of these while measuring the biometric parameters. First of all, coming to the measurement of the axial length is considered the most important factor because even the slightest error of 0.3 mm will lead to one diopter of post-operative error. So axial length we measure from anterior corneal surface to the internal limiting membrane in ultrasound biometry, and when it comes to optical biometry, we use it till retinal pigment epithelium, which gives us just a little extra edge. So coming to the ultrasound biometry, there are two types: applanation and immersion. Before coming to that, we use the 10 megahertz high frequency sound wave, which gives us low penetration but higher quality of the smaller details of the eye, which we need to see. So the speed of the sound is actually determined by the media, how much denser or lighter it is. So if it's a dense media, it will travel even faster. So considering due to the various changes in the ocular media, finally we get a total average velocity, which then gives us a spikes when we measure it in the form of spikes. As you can see on the slide, there's spikes from the anterior and posterior corneal surface, then lens, orbital tissues, and retina. So in the contact A scan, we just directly put the probe on the cornea, which gives us just an error due to the indentation. However, it is much more easier and convenient. And when it comes to immersion A scan, we use the methyl cellulose solution. So as you can see in the first photograph, the patient is being instilled the local anesthetic, topical anesthetic, and then the slit cap is kept, followed by the 1% methyl cellulose, and then the probe is kept. These days, we are using optical biometry, which has come into advance since 2000 after the introduction of the IOL master. Here we use the concept of phase difference. So what happens that the incoming beam is being split, and then they travel a different path, and then finally they recombine. Because of this, there's an interference pattern which is caused, and this interference pattern is then being analyzed. So these days we have mostly, if you divide it into 3 generations, the swept source OCT is being used by the IOL Master 700, which is mostly used because it can even detect axial length in the dense cataract also. Also, there are lens tabs. You can see the second one, the left one, and the IOL Master A500, which uses partial coherence interferometry. These days, we are using it because it's much more convenient, less technician dependent. However, it is expensive. So coming to keratometry, keratometry is a measure of the curvature of the anterior surface of the cornea across a fixed spot length. As we all know, the convex mirror, cornea acts as a convex mirror, and because of this, we use this. If we know the difference between the object size and the image size, and keeping it constant as a u as the taking of the distance of the object from the cornea, we can find the radius of curvature. So we can use it for the two types of keratometers. Basically use Zawel Sizots and Bosch and Long. So in this, what happens that since there's a constant movement of the eye movement of the cornea, there's a doubling principle is present, due to which to avoid this, we use prisms, one which is base upwards and one which is base out. As you can see in the image, the two doubling images are being formed, and then finally they are used for to measure it. These days we are again using automated keratometry, and other diameters are interchamber depth and lens thickness and effective lens position. Thank you. I would like to thank Maharashtra Ophthalmic Society to providing us such a great platform.
Thank you. Thank you. Vishnu.
A very nice presentation. The gold standard nowadays is optical biometer, but which formula is preferred for calculation of IOL power?
So we have different formulas, but these days the latest formula, Olsen's formula, is being used because it's taking into consider the lens thickness also as a C constant. However, sir, holiday formula and is also used, sir.
Holiday.
Holiday, yes, sorry, sir. Holiday formula.
Yeah, Barrett Pruke formula.
Which formula is used for shorter eyes?
Pardon, sir? For shorter eyes.
Shorter eyes, less than 22 mm.
Sorry.
The Haig's formula. Okay, suppose you have two K readings, one of them is steeper and one of them is flatter. Say, for example, 45, 45 is one and 44, 44 is one. Which is likely to be more correct? Steeper will be correct or flat correct?
So flatter curvature.
Steeper will be always, yeah, steeper will be always correct because flatter indicates that you're reading from periphery of the cornea. Cornea is steepest at the center.
Yes.
So steepest reading will be from center. If there are two readings, axial length readings, one is shorter and one is longer, suppose 20 and 23, which is likely to be more accurate?
So we will
smaller
be
or
accepting
longer?
So we will be accepting the longer axial length.
Why? What wrong in shorter axial length?
So in myopes, generally the patients, if there's a patient is myopic, or we need to see whether there's any posterior staphyloma.
You
Hello.
Indicates that you have simply compressed the cornea, and that's why the axial length has become smaller.
Yes.
So in the same patient, same two readings, if one is shorter and one is longer, take longer as an accurate one. Okay.
Thank you, sir.
How much is the difference will be seen in the readings if there is an error in axial length?
So,
Already
millimeter.
told,
For
equal to 1 diopter. He has
0.3
already
mm, it causes 1 diopter change, or if there's a 2.5 mm, if there's 1 mm change, then it will lead to 2.5 mm diopter change error.
Okay. Okay, good.
Similarly, 1 diopter error of corneal reading will make how much difference in IOL power?
So if there's a 1 diopter change, it will lead to this 1:1 ratio, sir. 1:1 ratio.
Fine. Okay.
Thank you.
Good.
Sir.
Okay. Thank you, Shubham.
Yes.
Okay. The next speaker is Dr. Srikant Das.
Yes, sir. So we are both sharing from the same laptop, sir.
Okay, okay. Dr. Srikant, go ahead. Share your screen.
So is it visible?
Yes, please go ahead.
A very good afternoon and a happy Independence Day to all the respected teachers, honorable judges, and all my colleagues. Myself, Dr. Srikanth Das, first year resident from Grand Government Medical College and Sir JJ Group of Hospitals. I'll be presenting on the treatment of neovascular glaucoma under mentorship of Dr. Rishabh Shah sir. So, what is neovascular glaucoma? Neovascular glaucoma occurs as a result of aggressive iris neovascularization, rubeosis iridis, which leads to progressive angle closure and rapid glaucomatous atrophy. Now, we'll quickly look onto the causes of neovascular glaucoma. Ocular vascular diseases like diabetic retinopathy, ischemic central retinal vein occlusion, central retinal arterial occlusion, Coats disease, and some ocular inflammatory conditions like chronic uveitis, endophthalmitis, miscellaneous conditions like malignant melanoma, retinoblastoma, and vitrectomy. So, treatment of neovascular glaucoma can be broadly classified into three subheadings: the treatment of primary etiology, treatment of ocular inflammation, and treatment of the raised IOP. Under the medical management, so medical management begins upon the detection of elevated IOP, and it is most successful when the disease is still in the open angle stage. We have drugs like beta blockers, alpha-2 adrenergic agonists, carbonic anhydrase inhibitors, which decrease the aqueous production. Carbonic anhydrase inhibitors, on chronic use, they also increase the US pleural outflow. Options to control ischemia, we have pan-retinal photocoagulation, which is the mainstay treatment, which is the main treatment of choice. Along with this, intravitreal bevacizumab has also been used. Our anterior retinal cryopexy, which is used as an adjunct to PRP when the view is not good for pan-retinal photocoagulation, pars plana vitrectomy plus endolaser. When adequate PRP is not possible, we should also consider other options, other retinal ablation modalities, including pan-retinal cryotherapy, peripheral transscleral cytophotocoagulation. So we'll first look into the photocoagulation PRP. Here, with an exposure time of 0.1 second, blue-green argon laser are used to create a spot size of 500 micron meter, 2 disc diameter above, temporal, and below center of the macula. About 1800 to 2000 burns in 2 to 3 sittings over 3 to 6 week period is used. Indications for for prophylactic use of PRP. It can be used in conditions of diabetic retinopathy where with the peripupillary fluorescein leakage undergoing lensectomy or vitrectomy, proliferative diabetic retinopathy. Intravitreal use of anti-VEGFs. Intravitreal bevacizumab should always be used irrespective of the media clarity and depending upon the media clarity, intravitreal bevacizumab can be combined with PRP or retinal cryopexy or both. Also before any trap surgery, it reduces the chances of post-operative hyphema. Few combination therapies which have been tried till date. Now onto the surgical management. Once the rubeosis regresses and the inflammation is resolved, glaucoma filtering surgery like trabeculectomy has been used. Trabeculectomy lowers the intraocular pressure by creating a fistula protected by a superficial scleral flap to allow aqueous outflow from the anterior chamber to the subtenon space. Along with this, we use 5 antimetabolites like 5-fluorouracil or mitomycin, which has got a reasonable success. In cases where the inflammation is still present or there are new vessels are persistent, we can use glaucoma drainage devices like Ahmed valve and Baerwald shunt. Most common complications of any trap surgery is hyphema. So before that, we can use intraoperatively IV bevacizumab. Here's a short summary of all the treatment protocol. Future treatment options includes anti-VEGF antibodies like bevacizumab and alpha interferon therapy, proxyretin. Conclusion: it's a devastating ocular disease which often has a poor prognosis. So the best hope is to prevent blindness is by continued research and to for the development of novel pharmacological agents to prevent or reverse neovascularization process in patients. Thank you.
Yes, good, Srikanth. How will you differentiate normal iris vessels from neovascularization?
So the normal iris, in neovascularization, the vessels are leaky, and in the normal iris vessels, they are not leaky. Also, in neovascularization, the vessels are mostly around the margins, around the pupillary margins.
Where does the neovascularization starts?
So it starts with pupillary margins and then it proceeds on to the body of the iris and then onto the angle.
Angle first or pupillary margins first?
So pupillary margins first.
Okay. What is the commonest cause of neovascular glaucoma?
So proliferative diabetic retinopathy is the commonest cause.
Have you told about cyclocryo?
So yes, cyclocryo cyclocryo can be used in conditions where the media is not clear. First we try with the pan-retinal photocoagulation. If the media is not clear, we'll go with the cyclocryo photocoagulation, cyclocryotherapy, where about -70°C is applied and to create hypoxia, which will reduce the oxygen demand.
Where is the oxygen demand? In ciliary body or in the retina?
In the retina, sir.
And you are treating where in cyclocryo? Cyclone is where?
Sir,
it is the process of freeze thaw which causes crystallization and decrystallization and breaks the cell membranes and destroys the ciliary body, thereby reducing the production of the aqueous. Okay. And how many clock hours it should be done? Cyclocryo.
Sorry, sir. I would like to.
Okay, fine. Okay, fine. We can have next.
Thank you, sir.
He is the last, I think. That's right.
Yes, sir. So we are done with all the speakers.
Thank you. Thank you very much.
Congratulations to all the speakers. Really, it was a nice presentation. Only thing I have to add to the speakers, you should have less words in your slides and more diagrams and more photographs. Many speakers were having a lot of words. It was difficult to read over there. So welcome back, Dr. Preeti, madam. I hope you had a safe journey.
Yes, I reached the airport and then I joined back again. Now I have good reception. Thank you.
Thank you.
So I heard the last two speakers. They were very good and nice. And thank you, the judges, for sparing their time. You know, it's always tough deciding. And congratulations to all the students.
Few comments I would like to make for students is, see, these are all presentations done as if you're doing a seminar, isn't it? Yeah. Here you are trying to bring out teachers from your inside. So emphasis should be on explaining a particular thought process and not only a presentation. A teacher explains how things are happening and not only a presentation of a topic. I found explanation of a topic or a process in hardly 1 or 2 presentations. Agreed? So
Yes,
take it a point that it is the teachers of tomorrow and it is not the presenters of tomorrow.
Yeah. But one thing, sir, you will be appreciating or observed is your first year, most of them, 3-4 were first year students and they have prepared very nicely and the topics were of highest quality, which we were doing even today. We are presenting on axial lens and all those. They were presenting on the first year.
That's what I am telling you. With slide share, all the material is available now. So what emphasis should be there is on the explanation of the processes. That is what we expect in teachers of tomorrow.
Yes, thank you, sir. But it was nice. Enjoyed the judgeship today.
Thank you.
Thank you, all the 3 judges.
Very nice presentation by all the participants. Very nice.